I'm about to introduce this, this panel, and I just want to say, so, when we put this event together, we started many months ago, but we asked for a lot of feedback from our Program and Policy Committee, from our Consumer Advisory Committee, from our board, and other members, and really saying, like, what feels important for us to talk about this year. And the issue of safe hospital discharge came up in a big way this year. So we're really excited to be able to have such an important conversation with this esteemed panel. And so I'm really excited for you all to hear and be a part of the conversation. We do, I'm going to introduce the moderator in a moment. We do, if you remember, if you were here for the first session, have a QR code inside your program. It'll also be up on the slide later. If you have questions for the panel, you can scan that QR code and enter your question. There's a place, if you have a specific panelist that you want to ask your question to, you can write that in. If that doesn't work for you, if you want a low-tech option, we have a bulletin board in the back with Post-its. You can go and write your questions, and we'll put those into the question queue. I'm guessing there's going to be a lot of questions for this, but please get those questions in. Okay. And now I am very pleased to introduce our moderator. Dr. Flávio Casoy is originally from Sao Paulo, Brazil. He completed college and medical school at Brown University in Providence, Rhode Island, general adult psychiatry residency at the University of California, San Francisco, and a fellowship in public psychiatry at Columbia University, New York State Psychiatric Institute. His primary areas of work at OMH include oversight of Medicaid managed care, mental health parity, and developing new capabilities for acute hospital care support, oversight, and technical assistance. He lives in Brooklyn with his husband, who is also a psychiatrist. We almost tried to get him on the panel, but we thought we've already have too many people up here. Anyway, welcome, Dr. Casoy. Thank you.
Hi, thank you so much, everyone. Thank you all for all the work that you do. It's really inspiring and really incredible. Thank you to the previous speakers. It was so informative. Thank you, Bonnie, for your leadership and convening us here, and to Christina for helping get us all organized, and of course to my colleagues on the panel who I think are so amazing, and we'll learn so much from them. So I just want to say a couple things as we get started. So part of, in response to Governor Hochul's really, like transformative commitment to changing the mental health continuum in the state, like fixing it, addressing the decades of disinvestment, the Office of Mental Health conducted dozens and dozens of forums all over the state, listening sessions to ask, what is happening, right? What is happening in the state? What do you need? And we heard very loudly and very clearly from outpatient providers, from residential providers, from nonprofits offering housing, local county officials, law enforcement, about their concern about the increasing medical and social and psychiatric and other acuity and needs that their clients are facing. And there was a general pervasive feeling that hospitals, emergency rooms should be doing more, quote unquote. Why was my client discharged so soon? Why didn't they listen to me? We also heard very loudly and very clearly from hospital providers that their counterparts in the community are never available to give information. It's extremely difficult to find residential placement for discharge. There are no outpatient appointments out there. The Office of Mental Health, my people, we take too long for psychiatric center referrals. There's, increasing violence on the units, and their staff are angry. The managed care plans aren't paying enough. And the county courts are just not fast enough with Article 9s and treatment over objective hearings. Nobody understands what we actually do here. Nobody appreciates us. It's the general feeling. And I think what we know is that everyone is concerned about staffing, right? It's just really hard right now. And everyone has the sense that the other parts of the system are not doing what they're supposed to be doing. But in fact, all parts of the system are overwhelmed and doing the best they can, and everyone is coming out of the pandemic clobbered and really trying to figure out how to get back on our feet. And it's our clients who are oftentimes falling through these sort of increasing gaps. So what do we do? So this is a reality. To begin addressing these issues, the Office of Mental Health has begun to issue guidance to hospital and community providers on how to better work together. We understand the limitations and the fiscal needs, and how do we create assistance for this part to work? We are also launching 2 new initiatives, a very local, individualized sort of planning process called the Hospital and Community Connections, to help hospitals, community providers come up with workflows to make it easier to talk, so it doesn't depend on John Doe or Jane Smith knowing who to call on every single program. So it can't just be on the basis of individual effort. We need workflows and processes, and also a whole new office that we're developing to provide technical assistance to hospitals on how to do better discharge planning and better coordination with the community. Hospitals have lost a lot of people, and there's a lot of knowledge that has been lost with retirements and people going, and we need to help sort of recreate that. So, summarize the flow of the panel. We're gonna start laying out the challenges to coordinating care around discharges for folks who are unhoused or formerly unhoused. We're gonna talk about the challenges, move into what's working well, and then sort of work on getting a sense of like, what your input and what your thoughts are. So please do submit your questions. As we get started, let me take a little poll. Show of hands. Who here is a clinician working in a hospital-based program? Raise your hand. Okay. Ambassadors, welcome. Who here is a clinician working in some sort of outpatient or community-based program? Raise your hand. Okay, and who here is working in housing nonprofit, that interacts with the inpatient and the outpatient system? Okay, most people here. All right, so good to know. So panel, you have a sense. Let me introduce the panelists, and then let's get started. So Al Nemhard is a urban anthropologist and survivor of 12 years without a permanent address in New York City. During that time, he was embedded in a Midtown East street community, gaining firsthand experience and insights into urban life. Al has served as a board member, manager, staffer, program designer, and volunteer for Crossroads Community Services, contributing to their mission of supporting vulnerable populations. With over 32 years of experience in investment banking and investment management, he brings a unique blend of professional and lived expertise to his work in community services and advocacy. So much experience, so excited to have this perspective. Dr. Amanda Ramsdell is currently an assistant professor of clinical medicine at Weill Cornell Medicine in the section of hospital medicine. She joined the Weill Cornell faculty in 2015 after completing residency and training at New York Presbyterian Columbia University Medical Center. In 2024, she completed fellowship training in addiction medicine and is currently the director of inpatient addiction medicine consultation at Weill Cornell Medical Center. Dr. Ramsdell is currently working with the New York Presbyterian's Division of Community and Population Health on projects to develop housing navigation programming at NYP Lower Manhattan Hospital. Super innovative. Dr. Dwight Kemp is board certified in public and community psychiatry. He serves on the board of directors of the American Association for Community Psychiatry. He completed a public psychiatry fellowship at Columbia University, where he was my fellow, where he served as a policy fellow in the Office of the Chief Medical Officer at the New York State Office of Mental Health. Dr. Kemp is a published scholar and speaker. Currently, he's unit chief of the Extended Care Unit at Kings County Hospital, leading an innovative program for individuals with severe mental illness who need more comprehensive care than traditional systems provide. Shauna Berry received her undergraduate degrees in women's studies and peace and justice studies at Fordham University and her master's in social work at Hunter College. She started at BronxWorks in 2009, working with chronically unhoused adults with serious mental health diagnosis, older adults, and opened up 2 supportive housing sites as a program director. Currently, Shauna is the director of clinical learning and development for BronxWorks, bringing clinical trainings, clinical supervision, and support to staff of over 1,000 employees at the agency. She also has a passion for fostering dogs. Last but not least, Naira Johnson is a licensed clinical social worker with over 20 years of experience working in healthcare navigation and public health programs. She oversees the New York City Department of Homeless Services Institutional Referral Program, which aims to ensure safety in shelter, support continuity of care from hospital to community, and prevent street homelessness. So let me extend my gratitude to the panel. And the opening question for each of our panelists is, each of you represents a unique perspective on this issue. Would each of you briefly introduce yourself and tell us what you see as the biggest challenges or problems with ensuring safe discharges for unhoused and firmly homeless individuals from hospitals? So let me start with Al.
Hi. Let me take that as my jumping off point and make a brief confession to you here today. I'm something. There we go. Okay, sorry about that. I'm going to use the question as a jumping off point to tell you a little bit about myself. And I've got a confession to make. I'm something of a ringer on this panel here, and I say that for two reasons. First, my fellow panelists are almost all either medical care providers or shelter providers and or directors, and I'm definitely not, okay? I'm most often a patient advocate, a patient representative, and sometimes I'm even a patient myself. So today, think of me as your patient avatar, okay? And I'll try to play that role as best as I can today. It's the one role that I think I'm well qualified to play. The second reason that I'm somewhat of a rogue here is that of the panelists here, if you look at the written materials, I'm the panelist without a string of letters or qualifications behind my name. And that's a deliberate choice that I made. I've got 5 degrees from respectable disciplines, from recognized universities, but none of that training or education or experience prepared me to be a patient. And so I decided I'd leave that out in my characterization of myself here today. What I do think will be relevant to you is, and our discussion here today, is that I am a trained and experienced battlefield medic / medical corps person. The military still hasn't gotten over the fact that it refers to the Navy and the Marines refer to battlefield medics as corps men. I've been working and trying to get them to fix that for a long time. Had no success at all. But in my role as a corps person, I've had patients myself, and I've been a patient, and at the end of 2 tours as a medic, I ended up hospitalized for a long stay and became an expert on being a long-term patient. So I think that'll help me represent and channel the patient psychology, the patient interest, the patient perspective. And so I'll try to use that experience to tell you a little bit about how the patient views the world. With that, I'm going to ask you to think of me as wearing a pink sign on my forehead that says patient, and I'm Al Nemhard, and you'll let me know later on if I represented the patients well. Thank you.
Hello, can you hear me? Okay. Yeah, it's just such an honor to be here. My name's Amanda. I am a general medicine doctor. I work in the hospital with hospitalized patients. I recently became an addiction medicine doctor as well. And I think I've mentioned to almost everyone, I have a lot of imposter syndrome being on this panel because I can guarantee what's that? Oh. Okay, I'll try to speak up too. Thank you. I have a lot of imposter syndrome being on this panel because I can absolutely guarantee my housing knowledge is less than the average person attending this forum. But I hope to bring the perspective of kind of like the lay healthcare provider, kind of the average clinician. I very vividly remember not knowing anything about the housing world until I met Patricia Hernandez and I started coming to these actual annual convenings. I started coming, I think it was maybe a year or two before the pandemic started, and I was already an attending physician. I had been through training, I had been practicing, noticing so many of my patients were experiencing issues with housing. My patients were mentioning things to me I had no idea about respite care, vouchers, safe havens, and I just wanted to learn more. And coming to, I think, the first consortium meeting, I just remember my mind was absolutely blown. I just remember it so vividly because I was enraged that the hospital had no idea this world existed. There was no knowledge about it. I was also very hopeful because I saw examples of healthcare systems that were incorporating in housing-specific programming, particularly like Montefiore and health and hospitals, obviously. And so through that time, over the last 5 to 6 years, have really just been trying to advocate for more standard of care related to housing. And so I hope I can kind of bring that view. We have so much to catch up on in medical training, just in the operations of our hospital. And we're really trying, but there's so many, kind of applicable concepts that I think it's actually pretty surprising. Doctors, clinicians are never trained in. And so we've been working, trying to teach medical students, residents, physical therapists, occupational therapists in our hospital, working really closely with everyone. We can talk a little bit later. We just launched a program, learning from all of you, learning from programs that exist. So we just launched a hospital-based housing navigation program. But I can speak to, kind of throughout this panel, kind of some of the perspectives of clinicians who worry so much that they are not serving their patients well. It is a horrible feeling to feel like you're not, able to connect somebody with the resources they need, or not even being knowledgeable about what's out there. So I think it's kind of a process, but hopefully we'll get to talk about this with this panel as well. Thanks.
Hello, my name is Dwight Kemp, and I am the unit chief of the Kings County Hospital Extended Care Unit. I have the wonderful honor and privilege to work with individuals with severe and persistent mental illness for whom traditional acute psychiatric care has been inadequate. And the extended care unit actually has another location, which is actually right here at Bellevue Hospital. The Kings County Extended Care Unit is the second of these units to be produced. The first was actually here at Bellevue and has been in existence for about 4 years. Shout out to my colleague, Kareen Zodum, who was the pioneer who put the program together. And the individuals that we serve are some of the most vulnerable and have the most complex needs of individuals with severe and persistent mental illness. They have a history of being recurrently hospitalized, multiple visits to emergency rooms, encounters with the criminal legal system, and in short, our system really has failed them. But with the good wisdom of Governor Hochul and Ann Sullivan, who is the commissioner for OMH, they saw the need, and they put together the pieces to make a program like the Extended Care Unit, where individuals who come to us, first of all, do so voluntarily. And they make the decision to take back their lives. It gives them agency. And in our program, we work with them heavily on psychosocial rehabilitation, but also we work with them on housing and benefits. We also work with them on occupational therapy needs for independent living. And so this is one small effort to support the individuals who are at greatest need within the mental health system. And I have the great honor and privilege to work with them.
Is yours? No? Yeah. Hi, everyone. I'm Shauna. It's good to see you all today. So I feel like with the poll, I think that we took earlier, I'm happy to feel like I'm in the room with my people who may know what it's like to be stuck at HRA all day, who may know what it's like to wait for your number on the second floor of the SSA building on 161st Street and be so excited when your raffle number is called to get your replacement ID with your client. So I'm happy to talk to people who I think have been at HRA with me before for the whole day. What I think I want to talk about today, very briefly, is that in terms of discharge and safe discharge and what that looks like and what that means, it's all about us trying to find and create opportunities. Opportunities to get and share information that I know the doctors want, that I have and want to give, or vice versa. So I think what I want to speak about today super briefly is how to find those opportunities and how to create that. And that to me looks like two big different chunks. That is data and the wonderful magic that can be the RIO. In New York, we have RIOs, the Regional Health Information Networks. I can log in and pull up people's blood work that I want to know upon discharge, if they're getting discharged with new meds that I have to start and get pharmacy refills for. I want to know data, and I want to know results and be able to show that to their social worker back at the respite supportive housing. So I love RIOs in New York. They are part of the SHINY. All these wonderful acronyms just mean that we want health information. And it's possible to get that from hospitals. So that's a great opportunity to find information that will help discharges work better. If you cannot run to the hospital and find that doctor right before or after their rounds before your client is discharged. The other thing I want to talk about of finding and creating opportunity is wanting to recognize the system of medical care and the trauma that it can create, or the trauma that can kind of be triggered sometimes, right? Because a lot of our people that we work with who we care about are frequent flyers. So they're in systems a lot, and systems are really, really hard. So I want to think about recognizing people's trauma response, right? And I want to think about shifting a narrative from what is wrong with you to like what happened to you, right? If we sit with that for a second and think about if someone's having a trauma response and recognize that while we're trying to like organize someone's instability of finding where they're going to stay tonight and when they're getting out of the hospital, that's all very scary. So those are things I think that I'm excited to talk about. So thanks for having me.
Hello, everyone. Good afternoon. I'm Neera Johnson. I'm at the New York City Department of Homeless Services in the Health Services Office. I've been there for a little over 3 years, and I'm overseeing our institutional referral program, among other projects. I'm here to just share a little bit about the institutional referral program and rationale and what we can do to support safe discharge planning to shelter, to support continuity of care and engagement in critical medical services in the community while in the shelter system, and ideally when transitioning to supportive housing or other residential options if available. So just, little background. The New York City Department of Homeless Services provides shelter to over 150,000 people a year. There's over 550 shelters. Approximately 50 mental health shelters at this point in time. And the primary goal of the agency is to provide a bed. So there's a lot of work that goes into ensuring that occurs, and as a result, there can be like shuffling around in the system. The standard intake process for shelter is to go to an intake shelter for a few hours, or an intake center for a few hours, an assessment shelter, which is in a different location often for an average of 21 days, could be longer, could be shorter, and then a program shelter based on bed availability at the time. Due to this process, kind of what some have described like crowd control, it's possible that a client who is discharged from a shelter, let's say from a hospital, let's say in Jamaica, Queens or something, could end up in a shelter in the Bronx, where they're far from their care, making it quite unrealistic to remain in care. Or it could be out of borough of their AOT team or their assertive community treatment team, ACT team, and this makes coordination of care very challenging. So I have been working on the institutional referral program for about 2 years to enhance and update the program to really work on coordinating, negotiating safe discharge plans with the hospitals to support continuity of community care, of care in the community. So we work with the hospitals to put special programs in place, mobile mental health programs like SOS and ACT. We have dedicated ACT slots that we can get placements for very quickly so that the client will leave the hospital with these critical mobile services. And then we coordinate shelter placement and expedited intake and assessment so that the person will go to the correct location in a shelter with the services they need the day of discharge, as opposed to several weeks later, to try to support that continuity of care. And then in an ideal world, we then will be building our capacity to follow up with these clients over time through our centralized complex case program, which works to ensure continuity of care and supports while the person is in the shelter system. So again, based on who's here, I'm really excited to have these discussions of how we can enhance our coordination together to ensure patients receive the services they need in the community.
Okay, thank you, everyone. Such an amazing panel, so much experience. All of you belong, no imposter syndrome. So I have a follow-up question that's really for all of you. So communication is essential for coordination. What are the biggest communication issues you see, and what recommendations do you have to improve communication? Go for it.
I'll start. And I've got to give credit here to a brilliant surgeon and writer whose name is Atul Gawande, who wrote a book a couple of years ago, 2009, called The Checklist Manifesto. And the subtitle was How to Get Things Right. In brief, what Dr. Gawande did was put together a series of checklists for each level of professional who had patient contact. And the objective was to avoid any and all avoidable errors that would impact either patient safety or medical outcomes. And this simple device, and it turns out it's not so simple, of having a checklist and going through that checklist every time you were going to have contact with a patient turned out to be a miracle worker. In being very, very modest, I've stolen a page from Dr. Gawande's book, and I've put together a checklist that focuses on this question of communication, information sharing, and connection. And I've got 2 lists. They're very simple. They've got 3 points in each of the lists, so it's easy to remember. And I've even made it a bit alliterative. So the first list all starts with E's. The second list all starts with A's. And again, since I'm wearing my patient hat here, all of this is done from the patient perspective, patient point of view. And so my first, list one says, what is it that the patient needs to know, okay? And on list one, I've got experience. What should the patient expect of his or her post-discharge experience? What's normal? How long should it take? What path, what pattern should that follow? What are bad signs? What are warning signs? What should he or she worry about or pay attention to? My second E, expectations. These are expectations of the patient, okay? What is it that the patient needs to be responsible for and aware of? And the obvious things like medication compliance, okay? Self-care. Can he, she, does he, she know what those requirements are, and can they fulfill them? And finally, what are reasonable precautions that the patient needs to take and take responsibility for so that their recovery and outpatient experience is on a positive upward trend? And finally, exceptions. Everybody's an individual, everybody is different, and so what is it about the patient's personal or family history? Are there comorbidities, genetic inheritance, exposures, work history, or experience history? What is different about the patient that really matters and is going to, we're all individuals, we all have differences, but what is, if there's anything about the exceptional nature of the patient that is going to be critical to the course of their care? And finally, what are the triggers to be avoided? What does the patient need to be aware of to stay away from, avoid, guard against? And so those are my, list one for the patient checklist, if you will. List two is, what is it that the medical professionals or care providers need to know and understand, again, about my patient, okay? What's the patient's age? Not their chronological age. That's the easy part. What is their physiological and mental age in reality, okay? We've got a lot of research and evidence now that there's a phenomenon called weathering. If you've been, as the British like to term it, living rough, living on the street, you are almost certainly going to be measurably older than your chronological age, okay? The street wears on you, okay? Secondly, what is the patient's fitness and mobility status, okay? I've dealt with patients who were retired athletes, and they were in remarkably great shape. I've dealt with patients who were sedentary all of their lives, and it was no surprise that, in fact, they were advanced in the aging that they evidenced anytime you gave them a thorough physical examination. For example, I had a patient who had a full body scan, and in which we discovered that the cartilage in every single joint that the patient had deteriorated. It was only a question of when the next joint was going to stop functioning, okay? And he or she was going to, he in this case, was going to be experiencing absolutely excruciating pain, okay? So again, what's the patient's functional effective age? Second A, if you will, on my second checklist, access, okay? What access does the patient have to straightforward follow-up medical care, okay? If you put together a discharge plan that requires the patient to see or have a medical test, okay, every 2 weeks, make sure that there's a way for them to get there, okay? Does the Project Renewal van stop at their drop-in shelter center, or does it not? And remember that that van is only going to stop there once a month, so that every 2-week regimen is going to break down almost immediately. Okay? Does the patient have the financial reserves and resources to actually fill that prescription that you have given him or her, and insisted that they comply with the medical protocol, the medication protocol? Okay, be realistic about it. Okay, I had a patient who was discharged from hospital for special surgery. The first thing that he discovered when he went to the pharmacy was that his required medication had a $300 copay. Think about it. Absurd. And finally, on access, does the patient have a social network? Somebody he can talk to, some community of folks who can support his physical, mental, and emotional health? Because absent that, you're in for a world of trouble. And finally, accommodations. What are the physical accommodations that the patient is essentially being discharged to? Is the space safe? Is it clean? Is it emotionally healthy? Is it secure? Okay. I spent 3 years in a men's hotel shelter with 100 senior men. The hotel was roach infested. I couldn't in good conscience let anybody be discharged from a hospital to that shelter, even if that was the only bed available in the entire system, because that made no sense. Okay? And finally, on accommodations, are there supplemental resources that are available? For example, can the visiting nurse service visit and assist a patient who's recovering from total hip replacement surgery, okay, and get him or her out, down, and exercising and walking every other day, every day, okay? The Project Renewal van, is that a supplemental resource that's available to the patient? And finally, in one program, we had a visiting podiatrist who could take care of the needs of the very many residents who had diabetes and whose foot health and foot care was absolutely critical. So those are my checklists, and those are the things that I've found. They're simple, they're straightforward, they work, and they've made a tremendous difference in the lives of the patients that I've dealt with.
I have a very quick answer. My very quick thing to add to this, because I think of like on the ground, so to improve communication, let's go to the hospital, let's bring blank HIPAA consents, right? Shout out to the 2557 HIPAA consent. Bring HIPAA consents and bring all the consents that you hopefully have who are their emergency contacts to next of kin, right? I think of like basic stuff that I know might sound basic to you, but might not to your new staff, right? That you're onboarding who are very overwhelmed by things. Get to the hospital. I love to find out when rounds happened, because all the doctors are there. So I like to find out when rounds were happening on the floor my client was. And then bring HIPAA consents, please, that you can have them fill out. Bring a RIO consent or a psyches consent. These are like medical EMRs you can access. And hopefully you have contact with their people, because the hospital, I think, loves to find out who is their uncle they actually talk to that they have a good support with, right? Al mentioned good support systems. Like, we want to make sure their support systems are being highlighted and shown, because those are the people that you've already confirmed are positive and supportive of your client.
I don't know how we can follow up after that.
Sorry.
That was absolutely incredible. But I just want to echo those things. Al, thank you so much for that checklist. I'm going to need to take that from you to make sure that I'm following and my team are following it as well.
Thank you.
Really amazing, and I really want to thank you as well because that was really tremendous. Personally, as a physician, I think Amanda, you feel this way as well. We always want to hear from loved ones. We always want to hear from individuals who are involved in the care, outpatient care of those that we're serving. I will tell you that it has been really a game changer on my unit because for the individuals that we serve, ACT teams will actually come to the hospital to see our patients and give us collateral about the patients that we're serving. We actually are very active in communicating because we work specifically on getting these individuals permanent supportive housing. So we've built relationships with the different housing agencies. And so they know us, they know about our patient population, and then we're able to find, our participants the appropriate level of housing. And so these kinds of connections, because the system is splintered, I think that's the most challenging part about it. We all, as Flávio indicated, talk about, the system being broken, the system not working, and certainly there are needs. But the truth is, because of how splintered things are, we're unable to maximize what resources are available. And so, us being able to tie these things together, like Flávio, what you were talking about, what OMH is doing, which I think is incredible, which is providing regulations and guidance and then technical assistance to hospitals to really work on identifying what resources out there, providing a workflow, because that's a challenge too, because we're all stretched to capacity, and it's really hard to integrate all of this new information and go on a search of it and meet, the deadlines that, all the pressures that are put on us. So, yeah.
I definitely agree with everything, and also I would love a copy of your checklist too. And yeah, just wanted to kind of touch on a few things too. Definitely agree with what everyone has said. A few other complicating factors just to add to the mix is a lot of those great points, especially in terms of the patient's ability to care for themselves, their physical conditioning. That's super dynamic. So if you know your client in the community and they have a certain set of resources, admissions, it takes a lot to get admitted these days. You have to be very sick. And so patients oftentimes have muscle atrophy, they have cognitive decline, they may be at a very different baseline when they're leaving the hospital. And so just the importance of communicating with people who, A, know the patient and can kind of compare and kind of change your differential diagnosis, what you're going to work up, really critical in that moment, and also for the discharge planning. And then also, hospitals are very guilty of this. There's not a ton of continuity of care of the provider with that patient. So in the hospital, every hospital is different, but a lot of it is shift work. So the nurses change almost daily. The social workers may change every few days. At least for where I work, the hospitalists change either every 7 days or every 14 days. But if you get admitted on a Sunday and I'm switching off into my 15th day that Monday, we have to be very careful about signing out like any of those contacts, those information. So that's also kind of, I'm sure, makes it much more challenging to get in touch with people too. So something we constantly try to work on, but I can imagine it's just very frustrating to get in touch with the team too.
Okay, and speaking about clients who are in the DHS shelter or safe haven or street system or going into it for the first time specifically, there is a tremendous opportunity while a person is in the hospital, because they are in care at the moment and can be found and can speak to clinical providers, to put these critical supports in place to increase safety in the community and access to care. I think the most challenging problems and issues in this situation are time, communication, detailed communication that has to occur in a very short period of time during the discharge planning process, which usually is like 1 to 3 days maximum. In rare situations, we have cases where we can work for a little bit longer to formulate a discharge plan. So I do think that to the extent the hospitals are able to start the discharge planning when they know a person is experiencing homelessness as early as possible, putting those mobile mental health supports in place as early as possible so that these teams, for those who have mental health issues, so these teams can meet them while they're in the hospital, engage and enroll and support transitions into the community is critical. And then also acknowledging that at DHS, we have the systems we have at the moment. I wistfully look at the news. The health department had a data modernization initiative and systems modernization initiative, and I was thinking, oh, that would be fabulous because our hospital referral process is conducted by email right now, and we receive over 4,000 new referrals to shelter per year. So it's a very high volume of people that we're trying to review. Half, about approximately, come from inpatient psych. About 40% have recent significant history of street and subway homelessness. So it's a very complex population, and it takes a bit of time to really figure out like what they will need to remain stable, what programs we need to coordinate with, ensuring the clients have a chance to learn about their options in the community, what they're about to face, and engage with their supports that will follow them into the community. So this is challenging by email. We're working on a variety of updates to our system to update our forms and ideally in the future have an electronic referral system and a unified referral system. Another complication with the email referral system we have is that our office, the central office, reviews new clients to shelter, but if a client has an assigned shelter or is a returning DHS client, the hospital is expected to communicate directly with that shelter. There is a lot of staff turnover, so it can be challenging to both, get in touch with the right person as well as have case history. The staff working at the shelter may not be clinical, so it's possible that they may not understand the full clinical picture of the client after reviewing the discharge paperwork. So there's a lot to do to bring our systems together on our side to optimize this referral process that we're working on as well. But hopeful, because I think we're making steps day by day to improve these systems.
Actually, Lara, let me give you a follow-up question.
Okay.
Can you say a little bit about kind of what options exist for individuals with more medical or psychiatric needs in the shelter system now? How to think about that?
Yes, sure. So once again, just the DHS system is a social service system that primarily focuses on providing a bed governed by the right to shelter law. So anyone who walks in to shelter each day should be getting a bed that day. And that is a tremendous undertaking in and of itself. We're also, under New York State regulations, not permitted to take in a client who has needs beyond what we are able to serve in our shelter system. So you have to think, because we have the issue of 550 shelters and a lot of movement throughout the shelter, you have to think not just of what one individual shelter that may have enhanced services can provide, but what the system is capable of providing overall. So a simple answer to this is that a person must be ADL independent to reside in shelter, particularly single adult shelter, because it's a congregate setting, and visiting nurse services and home health care services are not permitted routinely in this setting for a wide variety of reasons. And then also a person should not be a serious danger to self or others, particularly physical danger to self or others. that's a lot more challenging to deal with because oftentimes people will have nowhere else to go who is, chronically physically dangerous to self or others, and that's where we put the mobile mental health services and other supports in place to mitigate risk. There are shelters that do have enhanced services on site. My colleagues here, such as BronxWorks, has some of those shelters, Project Renewal, probably others here in the room, where there are some shelters with medical clinics on site, substance use clinics on site, some mental health services on site. As I mentioned, there's about 50 mental health shelters. However, these shelters you can't expect that they're going to be providing robust psychiatric services on site. They have fairly minimal security overall, so are not equipped to handle physically violent individuals for the most part. And some provide medication management services, but again, that's not available in all shelters. So if a person leaves shelter for a few days, the shelter where they were receiving these enhanced services, and then comes back, if there is no bed in the shelter that they were previously in receiving these enhanced services, they will have to be transferred to a shelter which may or may not have these services. So that is one of the greatest challenges we face. There are also shelters that do provide a bit more support when it comes to medical conditions. As mentioned here, there's mobile units that do come to shelters. We have a great partnership with the H&H safety net clinics and show vans now, some collaborations forming with some of our shelters to provide medical services in safe havens. And then there's various partnerships that shelters have independently set up with local healthcare providers. So as I describe this, I hope I'm conveying how complicated it is. And so when you're looking at a person who's coming to shelter, new to shelter, and you don't know for sure where they're going to land, it's quite, we have to think broadly, like what is the minimum level of service that we can guarantee this client will receive, and will they be safe with that service? Lastly, I'll just state that there is a reasonable accommodation request process. So hospitals, healthcare providers, mobile health providers, patients themselves or clients themselves can request accommodations to meet their needs if they have a disability, which includes medical, psychiatric, or all other forms of disability. And in some cases, the shelter system can meet those needs. So of course, ramps and features to address mobility issues, access to refrigerators, electrical sockets for oxygen equipment, et cetera. But we do not have, for instance, enough single rooms to accommodate all those who might need those for various reasons. So.
Okay, thank you. Shauna, you began to mention the Rio and the Shiny. Can you tell us a little bit more about how BronxWorks uses to provide better services, to support your clients, and a little bit about how you operationalize it for other nonprofits who might want to use it?
Sure. It's tons of acronyms. And in the next session, I believe after this, my wonderful friend Kathy from the Rio will be speaking as well, the panel after this, who's from the Rio. But New York has RIOs. RIOs are Regional Health Information Organization. It's just an acronym. But it's like just a way to share medical and psychiatric data. So at BronxWorks, we use the Rio and Psyches in some of our programs. This is voluntary, so the client has to consent to share this information. But the Shiny is like a support network in New York for health systems. So RIOs that are in New York State help spread information. So if your client says yes, you can just go into the system and pull up results of things. Time and time again, every time I go to any kind of a wonderful conference or a panel, I'm like saddened that people don't utilize them more. And they're becoming better and better every year, and they're getting more information in them every year. So at BronxWorks, for instance, we've set up a lot of systems with the Rio that we work with. We've been with the Rio. We helped start a Rio. We're on one of the committees for it like 10 years ago. So Rios are wonderful. We get alerts, which I just shout to my people here who have been to HRA. You want an alert if your client's admitted, if your client's been discharged, if you've been calling all the hospitals taking a lot of time and you cannot find your client. We get alerts, live alerts, if our client's been admitted or discharged and where they are. That's wonderful because then it can go to the hospital of where they are. So like in terms of safety discharge, utilizing the RIO is really wonderful. Alerts are a really great system for us. We also have something that we've created that's called a face sheet. So it's just like data that we've requested that we want for every client. So we want their last 5 hospitalizations. We want their last 5 diagnoses. We want to know, do they have history of using Narcan? They have history of suicide attempts or trying to complete suicide. We have a face sheet that we get on every client that comes to us when they sign a yes consent. RIOs are wonderful. I think by social service agencies, they're underutilized in New York State. Even though we have this robust system of them, they haven't really trickled down yet to people using them, and they're really wonderful. So we've kind of implemented them into work with some of our programs that have more long-stay clients, so transitional housing and permanent supportive housing. And it's a really great thing that we've been kind of spreading more and more. So I always get excited to talk about it because I think it can really improve communication because you all want this information. You need to make sure your clients can apply for different services, qualify for different entitlements, qualify for different types of housing. I've printed up so much stuff from the RIO to apply for SSI applications. This stuff is usable to you in the ground on the field. So the RIOs are really wonderful, and we've implemented them a lot at our agency.
Thank you. Let me ask a question for Amanda. Amanda, you began to talk a little bit about kind of the pressures that sort of the hospitals are, are under in terms of sort of discharge planning and so forth. Is there anything more that you want to tell us about this in terms of what you wish community providers knew about hospitals, and also just tying in there, what has your hospital done to begin to address some of these sort of needs that you're encountering?
Yeah, so a few points to respond to, I guess. I think, one just very basic thing that we're working on is just informing the care teams, the clinicians, that all of these organizations are out there and that the patients may have a history or be actively working with all of the great groups you're part of. So they need to ask the patient. I can't tell you when we were prepping for this how many times this has happened where for many different reasons a patient maybe didn't remember, wasn't able to say exactly who's involved, and I just barely missed the person coming to bedside, and the patient was like, oh, so-and-so was just here. I was like, what? I was like, that's the most important person I want to try to talk to today. I was like, they didn't say they were here, they didn't reach out. So definitely, if you do get an alert, your patient's admitted, you get to visit the hospital, you are the most valuable person probably the care team wants to talk to you at that moment. So definitely make yourself known, ask to talk to the doctors or social workers if your client is amenable to that. So just wanted to put that out there too. I can't tell you how many people I've either missed or run into in the hallway, and I had no idea they were part of the team, and it made an incredible difference, like creating a safe plan. And then to answer what we are trying to do and learning from places like Montefiore, University of Colorado, UVA, is feel very, very strongly that it really should not matter, what day you're admitted to the hospital, what team you just happen to randomly get, like how knowledgeable they are about all these systems. It is extremely complex. This is a specialty in and of itself. So we really wanted to create a model based on a lot of those programs where we have an independent housing team who can utilize a checklist like you mentioned. We'll incorporate some of those questions. And so it's standard for every patient. So it doesn't matter that my patient's crashing and I'm in the ICU, I'm trying to get them to the ICU for like 3 hours, or this person's off doing this, or somebody unexpectedly is like end of life, you're kind of dealing with that. So that we have somebody who's expert and focused on this and asking the same questions and kind of making sure all of those things are like systematically addressed, asked, and that we have a plan in place going forward. So Thank you to all of the hospitals who kind of helped us create that system. And yeah, our new team is over here in the row there. So I think it's been so helpful, and to the providers, they're so appreciative that somebody with expertise in these areas and all of this complicated system are doing that and kind of ensuring that we're exhausting kind of all our options and coordinating the care. But I think just to, kind of emphasize, I think it's super valuable to have a team that's systematically able to do that and provide that care, and even be that line of communication, even like you mentioned, to help with that.
Okay, thank you. And Dwight, a similar question for you, actually. A member of the audience submitted one of the questions that I was going to ask. Can clients who are in your unit, can they stay until safe housing is found to meet their needs? And I guess related to that question is, what's your track record of getting people into housing? You mentioned a little bit in your opening remarks how your unit is different from a regular old unit, but like in addressing the needs of this community, how are you able to better address sort of these housing needs?
Yeah, thank you for that question. So again, we're the extended care unit. We specialize in individuals with severe and persistent mental illness, many of whom experience homelessness and have a history of recurrent hospitalizations. And so our unit is specifically designed to address the needs to obtain, hopefully, permanent supportive housing for our participants. So we have social workers and community liaison workers that specifically work on getting our participants benefits. So, SSI, SSD, starting that application process if they don't already have it, getting those benefits turned back on if they once had them and, they were turned off, or if they've never had those things like cash assistance so that they have the income that they need to get into OMH supportive mental health housing, as well as, SNAP benefits so they have food to eat. And so we have the staff to do so. In terms of our track record, so the Kings County Extended Care Unit has been open since February of last year. And on our unit, over the data that we have available over the last 18 months indicates for those who were unstably housed or unhoused, 78% had an improvement in their housing status when they were discharged. And that number represents either getting directly into permanent supportive housing or into medical respite. And so I think that gives us a great opportunity to talk about the H&H Housing for Health team, which has been really instrumental in giving us support, particularly for medical respite. And so medical respite is a step down from an inpatient setting that gives individuals a recovery-oriented environment that they can continue in their own recovery process, and while they're working on other things in order to get into supportive housing. Medical respite works with the participants to continue that process that we started. And so it's really tremendous. So the difference, between, a traditional acute inpatient psychiatric stay and the extended care units is that our program is specifically designed for these individuals who are highly vulnerable, who have a lot of complex needs, and have not really been benefited from what we traditionally consider in a psychiatric inpatient stay. And I think because both the state and the city of New York with the Health and Hospitals and Governor Hochul and Dr. Ann Sullivan, who is the commissioner for OMH, responding to the need in creating units like this, and then the great wisdom of my colleague Corrine Zodum, who was the first to develop the extended care units, we're able to put in the time and the resources that these individuals need and deserve.
Thank you. So in terms of my last question in this sort of structured Q&A is for you, Al, as our avatar for truth. Do you have a reaction of what the other panelists were saying? And then from here, we received lots of great questions from the audience, and we'll start going down that list, yeah.
One of the things that everybody shares is that there's just too little interchange and too little awareness of pockets of information that can be safely, securely, privately accessed. Well, my fellow panelists have spoken about that problem existing from the professional provider side. It's even worse from the patient side, okay? I've been in shelter situations where the resident has been discharged from the hospital, comes to the assistant director of the shelter and asks for an accommodation so that he can go to aftercare. And the shelter assistant says, I don't know. I don't know. I'd like to help you, but I have no idea where and how I do that. Now, there are resources. How we get both the knowledge of those resources and the access of those resources to shelter administrators is one of the big challenges. Our patient see it as this is a spaghetti soup, and I have no idea which noodle in that spaghetti soup is the one that I need, and there's nobody around who can tell me where to put my chopsticks into the noodle, into the spaghetti soup, and pull out the noodle that I need. So, I mean, the sort of umbrella problem that we all share is we need more networks for sharing information, sharing that information securely, and since this is health information, making sure that it stays private, okay? I mean, I've been in situations where during the pandemic, we first had to advocate to get testing in a shelter that had, as I cited earlier, 100 senior men who were not going to have access to testing. Then when the vaccines came in, we had to again advocate to get vaccines on site. After we won those battles, we then discovered that instead of the information from the testing and the vaccinations being distributed privately and confidentially, it was broadcast in a, you don't have to worry because nobody tested positive. I mean, that was the HIPAA-compliant sharing of the information. And it wasn't that the director was ill-intended. She just didn't know. No one had told her how to distribute that kind of sensitive information. And so again, we're back to we need communication specialists embedded in this network of providers and clients and patients that can connect us all and share the information at the level that it needs to be shared and keeping it secure and private. I mean, I'm sort of, crazy about this whole thing of privacy, and that poor people need and value privacy as much as middle class and rich people, okay? And we have this thing that if you're indigent, you've given up your right to privacy. Nonsense, okay?
So we've received lots of great questions, many more than we have time to address, but But here's a question that's really about sort of keeping all of us honest. I think anyone on the panel can really take this. On the ground, quote unquote, I'm still seeing hospitals mainly discharging patients who are homeless to shelter intake, usually at 30th Street, where many people don't want to or won't go, and thus essentially the discharge is to the street. Yet hospitals seem to have no other options unless they've created their own respite program, aside from this discharge to intake, which is basically, in the opinion of this questioner, not a discharge. So what's a way to, instead of going to intake, to go to an assigned shelter or some other approach? It seems to this questioner that in the past 10 years, the situation on the ground is worsening and not improving. So from each of your perspectives, I know that this question is too big for any one person here, but like what's your reaction?
If it's okay, I'll just speak to the policy that is behind that. So there are several DHS intake centers, one for families, and then there's single adult men intake at 30th Street, which is the one in question, and adult family intake is there as well. And then there's 2 intake facilities for single adult women. Currently, presenting to intake center in person is required for new clients to shelter. And this is for a wide variety of reasons, in large part because there are often cases where hospitals discharge a person who is inappropriate for shelter, including arriving on a stretcher, can't walk, can't attend to their ADLs, everything, sadly. And so just having the ability to actually meet with a person in person is a requirement. And I know that I completely understand the reality on the ground, and we're doing our best to work on improving this, but one of the things I think is the most helpful is this process for high-risk clients of all sorts, and that could include people who have serious mental health issues, substance use, I guess, but it comes up more for people with serious mental health as well as medical conditions, to arrange accompaniment through the intake process. And we have worked on this expedited intake process, and we do hear feedback from the providers like ACT, SOS, et cetera, that this does go a lot better to provide them with that emotional support through the process. So that's what we're currently able to do. And then we're working on a variety of pilots, for example, with H&H to work on a virtual intake process, but that is to be determined how that will play out in the future.
Yeah, I can add to that. For specifically individuals that come to the extended care unit, often our patient population, going directly to a shelter intake system, it's not appropriate for those individuals. But I can relay that, for others who may have persistent mental illness and who may be more stable, having the accompaniment, as you described, certainly does help. Some of the patients that we've served have had that service, been accompanied, by an ACT team, and still didn't make it in, still disappeared, because it was not an appropriate setting for them, that the instability of a shelter environment is just too much for them. And so, at the extended care unit, we don't discharge to shelter because the patient population that we're serving, is so vulnerable and does need, a lot of support. And so we certainly utilize medical respite, through health and hospitals, the health and housing team. They help us get these individuals in and are prioritized because of just how vulnerable and the complex needs that they have.
I'll also add too, I know DHS, correct me if I'm wrong, and hospitals have been trying to form kind of a closer relationships in terms of hospital discharges. And I don't know if this exists, but I think feedback from DHS for some of the referrals that do not go well or inappropriate, giving direct feedback to those hospitals, I think would be really important, because I think just in all our learning, sometimes social workers, hospital systems just do not know the correct process, and they never know what happens after the patient leaves unless there's some mechanism or program involved. So I think if that's in the future, that would be great, but I think feedback to know when that wasn't a good idea, just so everybody's aware, would be really helpful too.
So just one quick follow-up question to, that both, Dwight mentioned, but also so curious for more information from Dwight, but also from you, Amanda. Can you talk about the role of medical respite in how you think about sort of this process and where it fits in?
Yeah, I will say that for us, medical respite has been a tremendous resource. And so it really, the way that we think about it is medical respite is an alternative to shelter that provides care in a supportive environment. And so these individuals can still be in the community and still get support that they need, where medications are given to them. And they can continue the process for obtaining permanent supportive housing. And so I can't say enough just how helpful how it's really been very helpful for our Housing for Health team, with whom we actually have monthly meetings to discuss prospective discharges and actually review discharges that we have had to medical respite and talk about how they're doing. So it's really been invaluable, because the goal for these individuals, because of their vulnerability and complexity, is to reduce the number of transitions that they have and to provide an appropriate level of support to them. And so we certainly utilize medical respite in that way. And it's been really helpful to us.
Yes, definitely agree. It's a super valuable concept, and our hospital is contracted with a medical respite provider. I think like a big learning lesson for us was that our hospital, it's like a huge hospital, was contracted, but the services were pretty underutilized. And I would have to say, as a doctor, most of my colleagues had never heard of the program or what medical respite was. So of course they're not thinking of it, oh, maybe my patient would qualify, let me ask about it, let me advocate for that. And so part of our work was asking, well, why is that? We have this contract, it's paid for by the hospital. Oh, the application's super long. Okay. Oh, people need IDs. People need some documentation collected. And so how could we kind of create a program to kind of meet those needs and, get more applications in? And I think since, even since we kind of got involved in it, a lot of the referrals have increased. And then it's kind of like a snowball effect. Like the doctors are like, oh my gosh, I never heard of it. And this is amazing. And my patient has a safe place to go. And so you create a really, a positive collaboration where, they're learning about resources, they're successfully happening, and the patient hopefully is really benefiting with a safer place.
So here's a question that came for you, Al. Can you share an example of a time when the systems successfully provided an unhoused individual with the care and support they needed after hospitalization? If you have a sense, what happened, what made it work well, and any other thoughts you have about that?
Yeah, this is one of my favorite examples, and I've used it in all kinds of settings. A 64-year-old male presented at a hospital emergency room with a severe scalp laceration, almost down to the dura, which is the outer protection of your brain tissue, okay? It took 23 staples to close the wound. As the physician was about to wrap up and prepare to discharge the patient, the emergency contact for the patient pulled the doctor aside and said, "Could you do me a favor? Could you keep this patient for observation overnight?" And the doctor said, "Yeah, sure, I can do that. But can you tell me why?" And well, the emergency contact said, "Well, the patient's going to be discharged and leave here. He's going to be alone. He's going to a space that I'm not sure is safe or protected, and I need 12 to 24 hours to arrange for a better situation." And so the patient stayed overnight. Actually, there wasn't a bed available, so booked up on a gurney in the hallway. And by the morning, the emergency contact had figured out a solution, and the patient was discharged safely, and the patient's talking to you right now. So you can do things. Very, very small, simple things.
Okay. Thank you for sharing. It's not easy. So for all panelists, really, for anyone who wants to answer this, this panel really stressed and highlighted the importance of cross-program and cross-sector collaboration. Many best practices were shared. Briefly, what is it that you need in your work in order to formalize, test, and scale these practices so they can become the standard of care? Briefly.
I can answer that one briefly. I'm back to my magic wand. If I had a magic wand, having a centralized electronic referral system for hospital, jail, and prison, and all referrals to shelter would really significantly improve things. Having to do a lot of the correspondence by email and keep email strings together and coordinate with all of these outside parties is just really overwhelming. We have a very small team, so many referrals, and the feedback idea that was mentioned, having such system would enable us to easily do better feedback to the hospitals, et cetera. And it's just that we're constantly just trying to keep up with new referrals every single day, and many of them are extremely, extremely high risk, and so it feels like a constant state of crisis. So having those better systems in place would be amazing.
So we're going to have a lightning round where, starting with that side of the table coming forward, all of you have to answer in a few words, like 30 seconds. What is one recommendation or solution that is achievable without sort of extensive policy or statutory changes would each of you propose to improve discharges? Go.
Electronic referral system.
I'm going to add her answer to my answer for DHS. 30 seconds or less, I would propose easy and quick more training for staff on mental health education, trauma responsive care, making sure people understand really uses of Narcan, what a trauma response looks like in a person, mental health first aid, training for staff, and more support for staff. Mental health days are helpful for staff as well.
I'm actually going to say utilization of the RIOs, the Regional Health Information Organization, because I don't use it, but yes, absolutely, because it sounds like this will give us, as providers, so much of the information that we often are missing to make a more comprehensive and safe discharge plan.
I completely agree.
And I'm going to pick up on something that we spoke about and mentioned earlier is the patient should always be accompanied by an advocate, family member, emergency contact, whatever. The patient should never present by themselves. They don't stand a chance.
I'm going to let that be the final word of this panel. And with that, let me hand it back over to Bonnie. Thank you to our panelists, and thank you to you all.
That was a wonderful discussion. I'm actually amazed. You all are such good rule followers with keeping that under 30 seconds. Well done. I was like, there's no way we're going to get to this in 2 minutes. Thank you all so much. Thank you to Dr. Flávio Casoy for moderating. Thank you for the rich discussion. I know there were so many good questions that we weren't able to get to, so please don't let this day be the end of this conversation. I hope that you had some takeaways and maybe meet some people at our happy hour later that you can talk to and really think through how we can make this process work better for folks and keeping the patient at the center. How did Al do as our patient representative? Okay, we will have a short 15-minute break and be back at 3:15 for our Medicaid waiver panel. Thank you all.